Welcome to Stago Educational Shorts. Short lectures covering the essentials of key coagulation topics. Presented by world-renowned experts. And designed to fit around your busy schedule.
Thanks for joining us today at this Stago Educational Short. Today we're going to be joined by Dr. Annette Bowyer. Dr. Bowyer is the lead scientist in the Haemophilia section at Sheffield Hemostasis and Thrombosis Centre. She has a PhD in cardiovascular science, which was awarded from the University of Sheffield, and it was awarded for a thesis surrounding diagnosis and monitoring of mild haemophilia. Today she's going to be discussing one of her research interests, which is the challenges posed by novel drugs for haemophilia therapies.
In this session, I'm going to address the laboratory aspects of some of the new haemophilia therapies that we are being asked to monitor in the hemostasis laboratory. So I think it's important that we have a look at our reagent profiles. Reagent variability between one-stage and chromogenic assays has been reported for decades. And in the one-stage assay, it's unsurprising because APT reagents are made up from activators such as ellagic acid, kaolin, silica, polyphenols, different phospholipids, phosphatidylserine, choline and ethylolamine at different concentrations. So overall, globally, there are more than 20 different APT reagents available. The table here, courtesy of UK NECRAS, shows a return for a factor VIII assay from earlier on in 2021, where 350 laboratories returned results using 14 different APT reagents, 9 different factor VIII deficient plasmas, and 13 different plasma calibrators. With a chromogenic assay, again, there are differences between the proteins and the concentrations and the dilutions. There are differences in reagents. If you measured a factor VIII or a factor IX on different analyzer platforms, you may see some variability with your results. And there are differences in the reference plasma that you use to calibrate your assays, so whether you use a product-specific calibrator or a plasma calibrator for calibration. So if we look at interlaboratory variability in the absence of any concentrates, this histogram here, again courtesy of UK NECRAS, is from a patient with mild haemophilia A. He has a mean factor VIII of about 30 units per decilitre. And the different colours shown refer to different manufacturers' reagents. And you can see there is a spread of results from up to very, very high levels of factor VIII activity. And again, for factor IX, this is a normal plasma. And again, variability is observed between laboratories. So if we look in a bit more depth at our chromogenic reagents, I've split these reagents into groups according to their reagent source. So the first 4, which are in the pale grey, all contain bovine factor X and bovine factor IXA. The 2 in the darker grey contain human factor IXA and human factor X, and those in the white at the bottom contain a hybrid or a mixture of bovine factor X and human factor IXA. So within our chromogenic factor VIII kits, there is a difference in the configuration of the factor X activation reagents. There are differences in the plasma dilution, 1 in 15 up to maybe 1 in 60. There are differences in incubation times from 90 seconds to 5 minutes, differences in the diluent provided to perform the dilution of the plasma. Some of these reagents come frozen, some are freeze-dried and require reconstitution. So in the same way that not all one-stage assays are the same, not all chromogenic factor VIII assays are the same. In 2018, we encountered our first factor VIII extended half-life molecule, Elocta, and the pharmaceutical company laboratory field studies concluded that there were no real differences between different APT reagents in the one-stage assay or the chromogenic assay for monitoring this particular molecule. So any assay was suitable for use. Since then, we've had a few more extended half-life factor 9 products added to the framework. And with each of these comes some difficulties with measurement with some of the different reagents. And more recently, last year, Adynovir was added to the haemophilia framework. And again, initial pharmaceutical company laboratory field study data suggested that there was no difference in monitoring by either one-stage assay with different reagents or by chromogenic assay. However, there's been a bit of conflicting evidence for this in a much smaller Swiss field study carried out in 8 laboratories. Plasma was spiked with Adynovir at 5 different concentrations spanning the range of measurement. Laboratories were asked to measure their response using either a plasma calibrator or a product-specific calibrator. And this graph shows one-stage assay results with the plasma calibrator on the top left-hand side and the product-specific calibrator on the right-hand side and the chromogenic assays underneath. And you can see that at increasing concentrations of Adynovir, a greater variability between results was obtained, and this discrepancy was removed by use of a product-specific reference plasma. We also see more discrepancy in factor 9 extended half-life products. So this is a very busy slide and I'll walk you through it. This comes from a global external quality assurance scheme exercise that was a collaboration between UK NECRAS, ECAT and the Australian EQA scheme. Plasma samples containing Benefix, Idelvion, Alprolix and Refixia were sent out to about 180 laboratories. They returned the results using either one-stage assays or chromogenic assays, and each of these panels shows the result for one of the particular concentrates at plasma that's normally got a value of 60 units per decilitre. And the dashed line on each graph shows the expected value. So the results were organised according to APT reagent and activator. So on the left-hand side of each graph are the silica reagents, followed by ellagic acid, followed by kaolin and polyphenols and so on. And the last 2 columns on each graph on the right-hand side show the chromogenic factor 9 results. So it's been reported by previous studies that measurement of the recombinant factor 9 product Benefix is underestimated when using a chromogenic factor 9 assay, and this can be clearly shown by the results for this exercise. This contrasts with Idelvion, where the chromogenic assay results overestimate the concentration of Idelvion, and Refixia, where the chromogenic factor 9 results are within target for Refixia, but certain APT reagents cannot be used. So some silica reagents underestimate, some silica reagents overestimate the concentration of Refixia. So moving on to Emicizumab. So Emicizumab has revolutionised haemophilia A treatment for patients, with around about 80% of our haemophilia A patients with inhibitors receiving Emicizumab prophylaxis and about 30% of our non-inhibitor patients in the UK receiving Emicizumab. So Emicizumab is a bispecific antibody which has recognition of human factor 10, human factor 9A, and it mimics the effect of factor 8 in the activation of factor 10. Now, it differs from native factor 8 in a number of important ways, but for laboratory testing, there is no on-off switch for Emicizumab. There is no need to activate the protein before you start to see 10A generation. And this infects our APT-based assays and our APT test. You get a short APT, which corresponds to a very high one-stage APT-based factor 8 assay. It's possible to modify the one-stage factor 8 assay by use of a product-specific calibrator and a higher plasma dilution to quantify the drug in micrograms per mil. And this will allow measurement of the drug, so you can ensure that the patient has got the drug in their plasma. Chromogenic assays that contain human-based proteins, so the two in the table I showed you earlier, are sensitive to the presence of Emicizumab, and these can be used to, again, indicate the presence of the drug in the plasma. Those chromogenic assays that contain bovine or a mixture of bovine and human proteins are insensitive to the presence of Emicizumab at therapeutic concentrations and can be used to measure any additional factor VIII treatment that may be given to the patient, and also can be used to measure factor VIII inhibitors in a Bethesda assay. So moving on to some of the newer products that we may expect to see in the near future. So BIV001 is a new fusion extended half-life factor VIII molecule. It contains a B-domain depleted recombinant factor VIII alongside two hydrophilic polypeptides extend molecules, and these prolong the half-life by steric shielding of this molecule. Unusually, it's also coupled to the D'-D3 region of von Willebrand's factor, and this confers an extension to the half-life of about threefold compared to standard half-life factor VIII. So a laboratory field study is being initiated for BIV001 with results expected by the end of 2021, and I'm expecting to see that there will be some differences between one-stage and chromogenic assays with this particular molecule. We're starting to see patients that have received gene therapy for haemophilia A and B in our laboratories. Factor IX gene therapy trials have been ongoing for almost a decade, and initially using wild-type factor IX, and more recently using a naturally occurring mutation known as Padua factor IX, which has a much higher activity for factor IX than the wild type. For factor VIII, all approaches use a B-domain depleted factor VIII and an adeno-associated viral vector to deliver the gene therapy. Assay discrepancy between one-stage and chromogenic activities have been described in both factor VIII and factor IX clinical trials. However, the laboratory data is sparse. So there's about 100 patients been treated with gene therapy, and there are a number of different dosing cohorts. So quite often there are only 4 or 5 patients in each cohort to try and work out what's going on with their assays. Not all methodologies used are disclosed by the clinical trials, and not all reagents are also disclosed, so it's quite hard unpicking some of the data. So if we look initially at factor VIII, this is a 2-year follow-up of Valrox, which is one of the gene therapy factor VIII approaches. And the data here shows the one-stage factor VIII in the yellow and a chromogenic factor VIII in the blue, and these are mean results. So at the end of 2 years, the mean one-stage assay results were 23 units per deciliter, and chromogenic 15 units per deciliter. So it confers about a 1.6-fold difference between the two results, although nobody can say which of these two results are the correct one, which is the most hemostatic result. We see a similar difference in gene therapy factor IX molecules. This is a multi-center laboratory field study using one of the factor IX Padua molecules. Plasma was spiked to 5 different concentrations using the Padua factor IX and circulated to almost 40 laboratories. And the results here shown are by APT reagent or by chromogenic result. And laboratories were asked to measure both the Padua factor IX and also a wild type. So the Padua factor IX results are in the dark red and the wild type in the grey. And an accurate measurement would give a result of 1, or where the dotted line is. So for most of the one-stage assay with different APT reagents, you are recovering close to the expected value. However, for the chromogenic factor IX, you're getting an underestimation of about 43% of what you're expecting to recover. And this wasn't specific to certain concentrations. So this was overall, the spiking was from high levels down to trough levels, and the ratio of one-stage to chromogenic was between 2 and 3 at all dosing concentrations. There might be a difference between the activity observed following the gene therapy, so known as the transgene activity, compared to the spiked plasma. So This much smaller study looked at 3 patients and 5 samples from patients that had been treated with a different factor IX Padua gene therapy. They investigated the difference with 4 APTT reagents and 1 chromogenic factor IX assay. And each of the different colours indicates one particular sample. So if we look at the top line, the results ranged from 30 to 58, in the one-stage assay, with a chromogenic assay around 21. So again, about 1.6-fold difference between chromogenic and one-stage assays, with one-stage assays recovering a higher potency than the chromogenic. So to summarise, we know that there are reagent and methodological differences out with the treatment of factor VIII and measurement of factor VIII concentrates or factor IX concentrates. It's really important that laboratories verify each particular product with their own panel of reagents. And for gene therapy, a lot more data is required. We need to know particularly what's going to happen if patients need to be treated with recombinant factor VIII or factor IX for surgery, and how's that going to impact on our assay recovery. And it's vital that there is good communication between the clinical team and the laboratories, so the laboratories understand which treatments are being offered in their centre and which patients are being treated with those therapies. If a haemophilia centre treats patients with a number of different concentrates, it will depend on the clotting factor. So for factor VIII, for most of the concentrates that we have, a chromogenic assay is acceptable, will recover as expected. For factor IX, it will depend on which of the concentrates are in use in your centre. So for example, Cephascreen APTT reagent can be used to measure all of the 3 currently licensed products in the UK. But for other companies' products, you may need to switch between chromogenic and one-stage assay. There are a number of important points that we've learned over the last few years with monitoring these new extended and novel factor VIII and factor IX therapies. Good communication between the laboratory and the clinical team is essential. We need to know in the laboratory which patients are being treated with which products, which treatments are likely to be used in the future, so we can prepare with our reagent sets and verify our assays for new products. It's essential that within the laboratory there's good communication between staff, so they know what to expect if a patient plasma is received in the laboratory and which assays should be used. So the presence of Emicizumab can be indicated by a shortened APTT in the laboratory, and to measure the drug concentration of Emicizumab in the patient plasma, you can use one of your Stago APTT reagents in a modified one-stage assay, which uses a product-specific calibrator and a higher plasma dilution to determine the concentration in micrograms per mil. To measure additional recombinant factor VIII therapies in a patient receiving Emicizumab prophylaxis, you need to use a bovine-only chromogenic assay such as electrochrom or a hybrid assay. So thank you for your attention, and thank you for Stago for inviting me to speak today.
Thank you for watching the Stago Educational Short. You can find other presentations by world-renowned experts on similar topics at www.stagowebinars.com. To learn more about the field of hemostasis and thrombosis, download iHemostasis from the App Store or Google Play Store onto your tablet. iHemostasis is a global education tool dedicated to the pathophysiology of blood coagulation, illustrated by clinical cases, designed for everyone from clinical professionals to students. You can also sign up to our newsletter to keep up to date with the latest scientific topics, educational materials and giveaways at stago-uk.com. For answers to the most important coagulation questions, listen to our Ask Stago podcast, available on all popular streaming services. You can also submit your questions by email at ask@stago.com.